Okay, good morning, everyone. So today is another very, very important topic, that what are the drugs which we can use in palliative sedation, because otherwise this remain always a matter of this thing, that which drug we can use. So I think systematically, Dr. Gayatri and her team will explain you what are the drugs which we can use for palliative sedation. And what for this, I will request Dr. Gayatri to introduce our speaker, Dr. Aruna, and that so that we will learn more about her. And if you have any question and answer, kindly write down in chat box. Dr. Gayatri and Dr. Aruna will take all these questions one by one. Thank you very much. Dr. Gayatri, you can introduce Dr. Aruna, please.
Thank you, Dr. Sushma, and very good morning to all of you. So it's with pleasure I introduce my colleague, Dr. Adumala Aruna. She is an anesthesiologist by training initially, and then she went on to do her postdoctoral fellowship in pain and palliative care, which is a university-run fellowship, which we used to do in M&J Institute of Oncology. She spent one year with us doing this fellowship. And after that, she was, I think, one of the first palliative care program in ESI hospital. Not that I'm aware of any other place, and a proper organized formal program approved by their highest authority. And this was officially sent by ESI administration for her fellowship, and she started this. I started palliative care in ESI hospital. While doing the fellowship, I remember her doing. She was so amazing, learning, very eager to learn, and just like a very junior student, eagerly following and trying to learn everything. And she did this remarkably so well. And during a period, she did have research work on oral methadone versus morphine for neuropathic pain, which is for review with the IAPC. And and very eagerly, she also participated in many conferences. And she helps us currently with a lot of her teaching activities. It's a very tough topic, understanding palliative sedation. I think we'll all learn from each other, but I requested Aruna to give some overview about some essential drugs which we use in palliative sedation. We'll just get, let's understand the drugs first, the medications which we use in palliative sedation, and then we'll go on to discuss some practical aspects. Over to you, Aruna.
Thank you, madam. Thank you very much for your kind words. Good morning to everyone. I think it is...
Yes, ma'am. We can see it.
Yeah, thank you. Thank you, one and all. So today's my topic is on drugs, common drugs used for palliative sedation. So coming to what is palliative sedation. So by definition, palliative sedation is defined as controlled induction of sedation, sometimes to the point of unconsciousness, to relieve the severe refractory suffering of a terminally ill patient. So what is meant by refractory suffering? It is refractory suffering means all the conventional treatment modalities could not give any relief to the patient. So everything tried, escalated doses tried, everything tried, but the symptom is refractory to routine conventional treatment, and patients continue to suffer. So the key point is that the level of sedation should be proportional relief from severe suffering. So here the aim is to decrease the suffering, and by definition death is never intended by palliative sedation. This is the difference between euthanasia and palliative sedation. One need to remember, euthanasia is the intention there is to end the life of the patient in order to relieve the suffering, but here in palliative sedation death is never intended. Then coming to what are the common indications for palliative sedation. So any refractory symptom, maybe physical symptom, neuropsychiatric, or any severe social problems. So coming to physical symptoms, severe pain, patient is unable to get relief with routine conventional treatment. Severe pain, severe dyspnea and vomitings. And next is your continuous seizures. When coming to neuropsychiatric problems, continuous seizures and delirium. Severe anxiety and depression, where both the patient suffers and the family suffers. And very rarely even severe social problems also we opt for palliative sedation. When there is an existential distress because of loss of dignity to the patient, and when there is a lot of discrimination and rejection from the family or from the society. This is a very rare condition, but this is one of the indication. Then coming to choosing of drugs. So what is the ideal medication for palliative sedation? So the drug should have rapid onset of action. It should have short duration of action. It should just induce sedation or unconsciousness and relieve the suffering with minimal side effects. Then it should easily facilitate titration to the desired effect. So this is the prerequisites. Then coming to routes of administration, to start with orally or rectally, but once in order to continue or maintain the desired effect, it is best route is continuous IV or subcutaneous route. What are the common drugs used in palliative sedation? Opioids, benzodiazepines, neuroleptics, barbiturates, and anesthesia induction agents like propofol, ketamine, and dexmedetomidine. Today's my topic is on benzodiazepines, phenobarbital, propofol, and ketamine. Today I'm going to discuss regarding a brief about physicochemical characteristics, pharmacokinetics and dynamics of the drug, clinical uses and their doses, adverse effects, immediate adverse and long-term adverse effects, caution where we need to be very cautious in the use of these drugs. What are the recommendations from our Indian settings and few case scenarios? Coming to the first drug, benzodiazepines, they belong to a class of anticonvulsant drugs. They are anxiolytics, sedatives, hypnotics, and they are GABA-mimetic drugs. So before going to these sedative drugs, most of their mechanism of action is on GABA receptor. So little few words about GABA receptor. It is a major inhibitory neurotransmitter of the central nervous system. It is a chloride channel made up of 5 units, 2 alpha, 2 beta, and 1 gamma. Among that, alpha is the most common one, and it has 6 subtypes, alpha 1 to 6. This is the diagrammatic representation. So 2 alpha, 2 beta, and 1 gamma. So the benzodiazepine action is between gamma and alpha. Coming to types, there are 3 types, GABA A, B, and C. And A and C are inotropic receptors, which are ligand gated. Their hyperpolarization occurs because of chloride entry, and GABA B is metabotropic receptor, which is G protein coupled. Their hyperpolarization occurs because of potassium exit. So alpha 1 is the most abundant form, and alpha 1 is responsible for sedation and prograde amnesia, anticonvulsant properties. Alpha 2 is the anxiolysis and causes muscle relaxation. Alpha 5 effect causes sedation and anxiolysis. Coming to the classification of benzodiazepines, they are classified depending upon the duration of action, short acting, intermediate, and long acting. Most common drugs used in short acting are midazolam and alprazolam. In intermediate acting, we use lorazepam and clonazepam. And in long acting, we use diazepam and chlordiazepoxide. Coming to the physicochemical characteristics, benzodiazepines are water soluble with an imidazole ring in its structure that accounts for its stability in aqueous solution, and they have very rapid metabolism, rapid onset of action. Solubility is pH dependent. At pH of 3.5, imidazole ring opens, so they are water soluble. And at body pH 7.35, imidazole ring closes and they are lipid soluble. And lipid solubility is the thing which causes the rapid onset of action. So these are available in 5 ml vials and 1 ml ampoules. Benzodiazepines doesn't cause any pain on injection. Coming to pharmacokinetics, pharmacokinetics of benzodiazepines are affected by age, gender, race, any concurrent use of enzyme induction drugs in case of hepatic and renal diseases, obesity. So we need to titrate the dose of benzodiazepines. Coming to the pharmacokinetic part of 3, each group I have taken 1, midazolam short acting, lorazepam intermediate acting, and diazepam long acting. Route of administration, they have variety of route for short acting. So oral, intravenous, intramuscular, subcutaneous, buccal, and nasal.
Now
but for
little slow, so that people understand. For us, many of us, it's very new.
Okay. Sorry. So for intermediate and long acting, we have oral route, intravenous, intramuscular, and sublingual. But there is no subcutaneous route for both lorazepam and diazepam because they cause irritation and tissue necrosis. So we don't prefer subcutaneous route for both lorazepam and diazepam. For midazolam, it is all the routes. So even for children, we can go for buccal and nasal sprays also. Coming to bioavailability, Except for oral and buccal and nasal, other routes it is almost above 90%. But for oral, buccal and nasal, it is almost 40 to 50% for midazolam. Then all are protein binding drugs. Then peak plasma concentration for midazolam is almost 60 minutes. For lorazepam, it is 120 minutes, and for diazepam, it's 60 minutes. So clearance is more for midazolam. Then elimination half-life is also more for depending upon their duration of activity. Volume of distribution is almost equal. The sedative dose of midazolam is 0.5 to 2 mg. For lorazepam, it is 0.5 to 1 mg, and for diazepam, it is 2 to 5 mg. Then they can go for an incremental doses. This is the minimal dose, starting dose. Metabolism of benzodiazepines occurs, midazolam and diazepam occurs through CYP3A4 enzymes. But lorazepam is non-dependent on cytochrome P450 enzymes. It occurs through another mechanism. Excretion, all these metabolites are inactive and excreted through kidney. Coming on to pharmacodynamics, the main effects on central nervous system are they cause amnesia. So amnesia was anterograde type of amnesia for benzodiazepines, and the duration of amnesia will be more than that of sedation. They cause decrease in anxious level. They cause good sedation. Then the incremental dose causes hypnosis. They act as an anticonvulsant drugs, decrease in the seizure activity. They cause spinal cord mediated muscle relaxation, reduces cerebral metabolic requirement of oxygen, and they are neuroprotective. Coming to effect on respiratory system, they affect in various ways. They affect on muscle tone, increases risk of upper airway obstruction because the tone of the muscle is decreased. Then the response of respiration to carbon dioxide is also flattened. Sedative dose of midazolam depresses the hypoxic ventilatory response. Generally, increase in carbon dioxide and decrease in oxygen drives the respiratory drive, but there will be flattening, decrease in that effect. Coming to cardiovascular system, they are hemodynamically stable. They will not cause any decrease or increase of heart rate, blood pressure, cardiac output, or systemic vascular resistance. So they are very stable hemodynamically, maintain stable hemodynamics. Reflex mechanism are preserved. Baroreflexes may be impaired when midazolam and diazepam used in very high doses. Then coming to clinical uses, common problem in cancer patients is insomnia. So it is almost alternate patient complaints of sleeplessness. Even if pain is controlled, they complain of sleeplessness. So oral lorazepam to start with 0.5 mg and can increase to 2 mg is the best drug. And subcutaneous midazolam wherever there is an admitted patient. The next is anxiety and panic disorders. Again, lorazepam is the best drug, which is an intermediate acting drug, and you can go for oral diazepam also. Then again, admitted patient, subcutaneous midazolam. Coming to seizures. So in acute condition, we prefer a lorazepam or midazolam. For children, it is buccal or nasal route. For adults, it is IV or subcutaneous route. Diazepam can be given rectal route, 2 to 10 mg. Then for chronic seizures, it is clonazepam, best drug. You can increase up to, start with 0.5 and increase up to 4 mg. And next is clobazam, which is starting is 20 to 30, and you can go maximum up to 60 mg. Next is myoclonus. Jerky movements, involuntary movements. These movements will be causing distress to the patient. So per oral clonazepam will control these myoclonic type of movements, or subcutaneous midazolam. Then coming to bedridden patients or stroke patients where spasticity and skeletal muscle spasm is more. So for them also diazepam is the best drug of choice. And again, subcutaneous midazolam is preferred wherever necessary. Then in case of terminal agitation, continuous subcutaneous infusion of midazolam is a drug of choice. We start with low dose 10 mg, then we can increase up to 60 mg in 24 hours. Then coming another indication is sedation for massive hemorrhage. Usually any case when we are anticipating massive hemorrhage, we load a midazolam syringe, 5 mg syringe, or 5 to 10 mg depending upon the situation, and we train the attender to just give the drug either any route, if already subcutaneous is there, subcutaneous or buccal route, so that the anxiety of the patient can be alleviated. Then coming to breathlessness, Anxiety-induced breathlessness responds well to benzodiazepines. So sublingual lorazepam 0.5 mg to 1 mg is preferred. Then admitted patients, again midazolam subcutaneous. Coming to restless leg syndrome, along with gabapentins, you can give clonazepam so that it acts as second line of drug, giving relief to the patient, 0.5 to 1 mg. So that is the dose of clonazepam. And coming to only one drug in benzodiazepines which is used for neuropathic pain. So clonazepam 0.5 to we can increase up to 4 mg. It is the mechanism exactly, we don't know the mechanism, but it gives relief along with the routine adjuvants in neuropathic pain. Preferred drug of choice in benzodiazepine group. Then coming to nausea, vomiting. So anticipatory nausea and anxiety-induced nausea responds well to benzodiazepines. Sublingual lorazepam is a drug of choice. Then coming to drug-induced movement disorders. Most of the cancer patients are on various drugs like anti-epileptics, anti-emetics like metoclopramide causing movement disorders. So clonazepam peroral is a drug of choice, or diazepam is also drug of choice when clonazepam is not available. Very less common uses where benzodiazepines are preferred are pruritus, hiccups, where they are used as second line or third line of drugs, and in alcohol withdrawals. Then in as a pre-medication drug in many conditions, midazolam can decrease the anxious level. Then to induce amnesia, and we can use benzodiazepines. So dose is according to the requirement. Coming to side effects, we have immediate side effects and long-term side effects. Immediate will be dose-dependent drowsiness. There will be impaired psychomotor skills. So we will ask the patient not to drive, and there will be cognitive impairment. We will any judgmental decisions we will ask them not to take when they are on these drugs. Then for clonazepam, there is secretion, increase in salivary secretions and drooling noted in children. Coming to respiratory depression, low doses or medium doses doesn't cause any respiratory depression, but high doses definitely will have some amount of respiratory depression. Coming to musculoskeletal side effect, it causes fatigue and hypotonia. So tone of the muscles will be decreased. So there is a high risk of fall or fractures in case of elderly patients. So initial, we should be very cautious in case of elderly patients. Coming to local injection, causes painful thrombophlebitis. For diazepam, it is a noted complication, so it should be given very slowly. And subcutaneous route is out of reach for both lorazepam and diazepam. Coming to long-term effects, tolerance. So first most long-term side effect is tolerance. Tolerance is you need to increase the dose to achieve the same desired effect. So tolerance is most common long-term side effect for benzodiazepines, and next is your physical and psychological dependence. If they are used for more than 4 to 6 weeks, then risk of dependence is seen more for these drugs. Then there is risk of dementia in elderly patients, again risk of fall and fractures or long-term use. And there is a preservative called propylene or benzyl alcohol used in lorazepam, which causes accumulation and can lead to toxicity in some patients. The toxicity symptoms are drowsiness, seizures, cardiac arrhythmias, and renal failure. So long-term use of benzodiazepines causes increase in morbidity and mortality along with their original medications. Causes suppression of hypothalamic and pituitary adrenal axis. So what are the contraindications? There are not absolute contraindications in benzodiazepines because in low doses they are very safe drug. So relative contraindications are any chronic respiratory diseases, hepatic and renal impairment. You should decrease the dose of the drug. Then any history of drug abuse. So abuse potential is more. So you should be very cautious. And benzodiazepines increases the suicidal risk tendency. If somebody is having a risk of suicidal ideations, then it increases. So, and elderly patients, this is very important. There is very high risk of fall. Then in severe hypovolemia or hypotension also we avoid. Coming to drug interactions, what are the significant drug interactions? Since benzodiazepines are metabolized by CYP3A4, any drug which causes inhibition or induction. So these drugs we should be very cautious. Drug which causes inhibition of CYP3A4 causes potentiation of benzodiazepine effect. So there you have to monitor the sedation. Then inducers of CYP3A4 causes decrease in the benzodiazepine efficacy. So you have to increase either the dose or go for an alternative drug which doesn't metabolize by this route is lorazepam. Then concurrent use of alcohol or narcotic analgesics, any antibiotics like ciprofloxacin, beta-2 receptor blockers, all these also potentiate the sedative effect of efficacy of benzodiazepines because not through CYP, but because of other mechanisms, unknown mechanisms. So we should be cautious and we have to adjust the dose, monitor for excessive sedation. Then levodopa also causes exacerbation of Parkinsonian symptoms when used along with benzodiazepines. So monitor and adjust the dose accordingly. Then coming to recommendations for Indian settings, benzodiazepines are very safe drugs which can be used and trained to all the healthcare workers in the palliative care. These are the first line of drugs used for palliative sedation because the safety is margin is more than their complications. So they can be administered by various routes. That is the most important thing. And it doesn't require any expertise or special training. Routine training is enough to use this benzodiazepine group of drugs. But when they are used for more than 4 weeks, we should be careful because of its addiction potential and tolerance. Then when we want to taper it off, we have to do it very slowly once the desired effect is achieved. Next is phenobarbital. These belong to barbiturate class of drugs. They are anticonvulsants and GABA mimetic, and high doses, they are anesthetic drugs. Mechanism of action, as I told you, all act on through GABA receptors only. They enhances postsynaptic inhibitory effect of GABA by prolonging the opening of chloride channel. They also act, phenobarbital also acts on AMPA glutamate receptor as an antagonist. Low doses of phenobarbital causes CNS depression, and very high doses causes general anesthesia. So route of administration is limited for phenobarbital. It's oral, rectal. Then IV form only. This is also cannot be given for subcutaneous route because of its potential for tissue necrosis and irritation. Coming to pharmacokinetics, important feature of phenobarbital is that it has inter-individual variation. So each individual responds differently. So you should be very cautious, start with low dose and then increase gradually. Bioavailability is very good for oral and rectal route, 90%. Onset is takes 5 minutes for IV and 30 minutes for other routes. Then time peak concentration is 30 minutes for intravenous route and 2 to 4 hours for the other route of administration. Then plasma half-life is 2 to 6 days, more for adults, less for children, 1 to 3 days. Coming to pharmacokinetics, they are strong inducers of CYP3A4 enzymes. So their metabolism occurs in liver by oxidation, dealkylation, desulfuration, and finally destruction of the barbituric acid ring. They are metabolized to inactive water-soluble metabolites and they are excreted through kidney. If you want to increase the excretion of the drug, alkalization will increase the excretion of the drug. Coming to pharmacodynamics, factors which influence their mechanism of action is dependent on their pH, lipid solubility, degree of ionization, protein binding capacity, and plasma drug concentration. Any drug, all these are very important actually. So phenobarbital is more, for barbiturates, it's more important. So coming to its effect on central nervous system, there is dose-related depression, then decrease of cerebral metabolic requirement of oxygen and cerebral blood flow, slows down EEG activity, so that is why their anticonvulsant effect. Then it causes protection in low doses, causes protection by decreasing the seizure activity and also causes the protection of cerebral ischemia. They have high lipid solubility and low degree of ionization, which is responsible for their fast onset of action and crosses easily blood-brain barrier. Coming to cardiovascular effects, primarily they cause peripheral vasodilatation, causes pooling of blood in the venous system. So cardiac output decreases because of direct negative inotropic action on the heart, and there is decreased venous filling because of peripheral vasodilatation. Heart rate increases and also cardiac index and mean arterial pressures are unchanged. So overall, there is a little bit of decrease in blood pressure. Coming to clinical uses and doses, mainly they are used for status epilepticus. So they are phenobarbital is used for emergency treatment of seizures which are refractory to routine benzodiazepines. and the first line of along with the first line of anti-epileptics. Usual dose is 10 to 15 mg per kg body weight. We can increase and go up to maximum dose of 1 gram. Then coming next use is terminal agitation in case of palliative care patients. So when in terminal agitation, it is used as a third line of drug when there is no response again to the routine benzodiazepines and antipsychotic drugs. We start dose with the 200 mg, slowly increase to 600, then 800 by continuous intravenous route. Then even the dose can be increased slowly from 800 to 1200, and 1600 for 24 hours is the maximum dose in case of terminal agitation. Next use is alcohol withdrawal. So for first line of drug is again benzodiazepines. When they fail to control the symptoms of alcohol withdrawal, we choose phenobarbital with a dose of 200 mg IV start. Then we can repeat after 15 to 20 minutes if necessary. So these are the three main uses of phenobarbital. Then coming to drug interactions, it's a strong inducer, as I already told you. It is a strong inducer of various enzymes along with CYP450 enzymes. So because of this nature, they reduce the plasma concentration of various drugs. So you should be cautious. What are the common drugs used in palliative care? Are opioids, antipsychotics, then antifungal agents, oral anticoagulants, and corticosteroids. So they decrease the plasma concentration. So we need to adjust the dose when we are adding phenobarbital upon these drugs when where their efficacy will be decreased because of a decrease in concentration. So this is very important. Then coming to route of administration, phenobarbital should be administered via separate syringe driver because of its high pH 9.8. It is not compatible with any of the palliative care drugs, most of the palliative care drugs. So it should be given in a separate syringe driver if you want to go for an infusion. Phenobarbital with acidic drugs causes precipitation. So before administration, you should be very cautious and don't mix with any type of drug. Coming to adverse effects. Immediate adverse effect is dose-related drowsiness, lethargy, ataxia, irritability, and restlessness. And in elderly patients, sometimes it causes paradoxical excitement, hyperactivity, and delirium. Respiratory depression is not for a low dose of phenobarbital or barbiturates, but it is more for high doses, respiratory depression. Coming to long-term effects, when used orally or rectally for long-term, there is a chance of megaloblastic anemia, but it responds to folate drug, so folate-dependent megaloblastic anemia, osteomalacia, and same toxicity because propylene is the preservative added in phenobarbital. So toxicity upon longer usage of this, almost 14 grams is the maximum dose for toxicity of propylene glycol, which is the preservative. The symptoms will be confusion, drowsiness, seizures, and arrhythmias and renal. Coming to contraindications or cautions, absolute contraindication is acute intermittent porphyria. Others are relative because in elderly and children we need to be cautious, and in renal failure and hepatic failure, decrease in the dose is required. For cardiac patients, and we need to be very cautious because of hypotension and depressant effect on the cardiac output, everything. So you should be cautious, decrease the dose of phenobarbital. Then avoid sudden withdrawal of phenobarbital. Once you get a desired effect, you have to slowly taper it off because if you suddenly withdraw the drug, causes rebound seizures. Comparing benzodiazepines with barbiturates, safety margin is more for benzodiazepines than barbiturates, and tolerance, abuse potential, addiction, drug interactions, and hepatic enzyme inductions are less for benzodiazepines when compared to barbiturates. So at any day, benzodiazepines are the safest drugs. There is an antidote for benzodiazepine over toxicity, like flumazenil is the drug, but for barbiturates, there is no specific antidote. Only for oral barbiturate overdose, we can go for an activated charcoal. Coming to next anesthetic drug is propofol. So propofol is an anesthesia drug, which is not routinely used in palliative care. It's used only by a few people who are trained.
Aruna, I just I request like all of you, I know it's like a lot of information. If anything, just keep putting it on the chat so that we'll all take it up in the end of the session. So please put it on the chat if you have questions or your own experience if you want to share. Thank you.
Sorry, I will go through fast a little because I have to talk about 2 more drugs. So propofol is anesthetic drug. It is 2,6-diisopropyl-phenyl. It's highly lipid soluble, pH of 7. So it's a slightly milky white liquid drug, stable at room temperature. Formulation contains these ingredients which are useful, like it's 10% soybean oil, 1.2% purified egg phospholipid, which acts as an emulsifier, and 2.25% glycerol, which acts as a tonicity adjusting agent. And sodium hydroxide is required for changing in the pH of the drug, and EDTA was added for its bacteriostatic activities. Coming to pharmacokinetics, very large volume of distribution is there for propofol, almost 60 liters per kg. Then distribution half-life is also very less, 2 to 8 minutes. After a single bolus dose, blood propofol level decreases because of its rapid redistribution and elimination. Elimination half-life is 4 to 7 hours. Clearance is very high, and time to peak effect is just 90 seconds to 100 seconds. The context-sensitive half-life for propofol infusion is less than 40 minutes for 10 hours infusion, or 1 to 3 days for a 10-day infusion. Coming to pharmacokinetics, metabolized by oxidized, propofol is oxidized and conjugated in the liver to glucuronide and sulfate. And these metabolites are inactive, excreted through kidney. Extrahepatic metabolism is there for propofol. Even there is decreased blood flow or hepatic blood flow, even then there is no effect in its metabolism. So there is extrahepatic metabolism in renal 30% and in lung 30%. Coming to mechanism of action, again activation of chloride channels of GABA receptors, thus enhancing the inhibitory synaptic transmission. Inhibits NMDA type of glutamate receptors. Onset is very fast, 15 to 20 seconds, and duration is for 3 to 5 minutes for a single IV dose injection. Coming to pharmacokinetics on the central nervous system, there is a dose-dependent decrease in the central nervous system. So the dose-dependent depression of central nervous system with initial low doses causes increase in dopamine, which is gives the sense of well-being for the patient. There is also decrease in serotonin levels in area postrema, this is the cause for it, antiemetic action, causes suppression on EEG, so that the anticonvulsant activity is decreased, causes amnesia. Propofol and midazolam have same amount of amnesia, and they are more when compared to barbiturates. There is a reduction of CMRO2, cerebral blood flow, intracranial pressure, and cerebral perfusion pressure. Coming to respiratory system, the main effect is there is an apnea. If you given a little bit fast, and very noted complication is that you should be very careful with propofol, causes apnea, and along with opioids, the apnea period is increased by 30 seconds. It causes bronchodilation, so very safe in case of COPD patients. Coming to infusion, in infusions less than 100 micrograms, the tidal volume decreases by 40%, and in respiratory rate increases a little bit, 20%, and the minute ventilation becomes unchanged. But higher doses of infusion causes decrease in tidal volume, and so minute ventilation decreases. You should be cautious when going for more than 100 micrograms infusion. Coming to cardiovascular effects, there is decrease in the cardiac output, decrease in the systemic vascular resistance, thereby causing decrease in the blood pressure. Cardiac index and stroke volume, heart rate, they will not be changed much. Decrease in blood pressure is more for propofol when compared to barbiturates. So baroreceptor reflex is depressed by propofol at high doses, causing bradycardia and asystole. Coming to its effects on liver and kidney, prolonged infusions should be very cautious because it causes the excretion of cloudy urine because of uric acids in the urine, or excretion of green urine due to phenols in the urine. But that doesn't indicate any renal impairment, they are safe. But the prolonged infusion definitely affect the liver. So hepatocellular injury is noted, associated with lactic acidosis, bradyarrhythmias, and rhabdomyolysis. So you should be cautious in case of hepatic. Coming to clinical uses, propofol is used as an induction agent for general anesthesia and for daycare procedures. And ICU sedation is a preferred drug when patient is on ventilator. Coming to palliative care uses, they are used as an antiemetic. It decreases chemotherapy-induced nausea, vomiting, and postoperative nausea, vomiting. The minimum dose is 10 to 15 mg. It can be repeated after every 10 to 15 minutes. Another clinical use is as an anticonvulsant. Low doses, 1 mg is enough for its anticonvulsant activity. Decreases seizure activity during ECT procedures also. And for antipyretic effect also, propofol is preferred, and that is a low dose only, 10 to 20 mg. Then it has another good properties. It's an antioxidant, inhibits lipid peroxidation. Coming to adverse effects, immediate adverse effect is pain on injection. One important thing for propofol is it cannot be given in any other route. It's only intravenous route, and you have to go have a good IV line. So even with good IV line, you have pain on injection. So to decrease the pain, you can give xylocaine or opioid. Then and apnea is the common problem with propofol. So it should be given very titrated dose and slowly. Apnea and hypotension are noted for propofol. Then coming to induction, during induction, there can be a mild headache or proconvulsant activity. There is abuse potential and intense dreaming because of its increase in dopamine levels and initial increase in dopamine levels. Then hallucinations are very rare, but they can be there. One is pain on injection with thrombosis and phlebitis along the line of injection. So allergic response in case of patients who are allergic to lecithin, egg, and peanuts. Long-term effects are bacterial contamination of the vials, so bacterial growth, then increase in the lipid levels leading to pancreatitis. So any patient on chronic infusions, you should be cautious about all these things. And one special thing is regarding the propofol infusion is propofol infusion syndrome that I will deal subsequently. So to avoid the bacterial contamination, it will be given by intravenous only. Then the ampule or the vial should be disinfected with 70% isopropyl alcohol. Contents of ampule should be transferred to sterile syringe. Any open ampules or vials should be discarded within 6 hours of opening. So when patient is on continuous infusion, tube carrying propofol to be changed every 12 hours. These are the precautions need to be taken to avoid bacterial contamination. Coming to propofol infusion syndrome, it's a very rare syndrome, but lethal syndrome. It occurs when the dose of propofol is more than 4 mg per kg per hour, or used for more than 48 hours. And mostly in children and infants, it is noted. Then the signs and symptoms include acute refractory bradycardia leading to asystole. This is because of acute myocardial injury leading to lactic acidosis, hyperlipidemia, dysarrhythmias, rhabdomyolysis, and hyperkalemia. The management is just stop the drug, stop the infusion, stabilize hemodynamically. If necessary, go for hemodialysis. Coming to contraindications, mainly cardiovascular system, because they cause depression of the cardiac effects, though in arrhythmias, heart failure, and any prolongation of QT interval, sepsis, shock, so absolutely contraindicated propofol. And coming to central nervous system, epilepsy is a relative contraindication. In respiratory, it's almost safe drug, but in interstitial lung diseases, avoid. Then in hyperlipidemia, because of risk of pancreatitis. Hepatomegaly also, infusion causes hepatocellular damage, so you should be cautious. And any patient who are allergic to eggs, soya, and peanuts. And it already told cannot be given by subcutaneous route, only IV infusion. So coming to palliative indications of propofol are mainly used in agitated delirium, then intolerable distress in imminently dying patient. Patients who want conscious sedation with careful titration, you can stop the drug. When you stop the drug, patient can recover fast. So when anyone requests for some sedation or conscious sedation, if you want to give to the patient, you can prefer propofol. Then as an antiemetic for refractory nausea and vomiting, can be used rarely for antipruritic effect and to decrease the anxiety and as a muscle relaxant. Coming to last drug, ketamine, it belongs to phencyclidine group of drugs, is an anesthetic drug. It causes dissociative anesthesia, state of unconsciousness with cataleptic state. It has profound analgesia. Patient's eyes are open, but they maintain the reflexes, corneal, cough, and swallow reflexes are well maintained. They have good amnesia, but amnesia is less when compared to benzodiazepines. Coming to physicochemical characteristics, it's a racemic mixture. So S form, R form, and racemic form are available. S form is more potent. It has good analgesia and rapid metabolism, have less of side effects, high clearance, and the potent suppression of for EEG. Coming to bioavailability. So intravenous, it's 100%, intramuscular, it is 93%, and intranasal, almost it is 8 to 45%, oral 17 to 29%, and rectal 35%. So various routes are available for ketamine. Coming to pharmacokinetics, it's only 12% protein bound, high lipid solubility. So good volume of distribution, and then half-life is 11 to 16 minutes. Clearance is almost good. Elimination half-life is only 2 to 3 hours. So rapid onset of action. The onset is within 30 seconds and peak action is in 1 minute. The rapid onset is because of low molecular weight, high lipid solubility, and pH. pKa is same as that of pH of the body. Coming to pharmacokinetics, metabolism occurs in liver to norketamine by N-demethylation. This metabolite is active. Norketamine is active metabolite. Then again, it is hydroxylated to 4,5,6-hydroxynorketamine. Then again, it is conjugated to glutamate derivatives. All these metabolites are inactive. Final metabolites are inactive and excreted in urine and bile. Coming to mechanism of action, ketamine has main important mechanism of action is through NMDA receptors as the antagonist action, but they also act on opioid receptors, mainly mu receptor of the opioid. But at very high doses, it also acts on sigma receptors. The other receptors are monoaminergic receptors and muscarinic receptors, through which it increases the secretions. Then it also facilitates GABA. Coming to these effects, ketamine effects on central nervous system, they are sympathomimetic, increases salivation, lacrimation, pupils are moderately dilated. You have nystagmus, and there is increase in the muscle tone. They prevent nociceptive central hypersensitization, and they cause decreases the opioid-induced hyperalgesia, increases cerebral metabolism, and increases cerebral requirement of oxygen and cerebral blood flow, intracranial pressure, all are increased. Cerebrovascular response to carbon dioxide is prevented. That's why respiratory system, that they do not have much effect. So slow injection is safe, doesn't cause any respiratory depression, but increases the respiratory rate. So minimal effect on respiratory system, so acts as a bronchial smooth muscle relaxant. So preferred for reactive airway diseases or bronchospasm or in status asthmaticus, preserves all the airway reflexes, improves pulmonary compliance. So safe in respiratory, bronchial asthma and respiratory diseases. Coming to cardiovascular, it has both direct and indirect effects. Large doses are depressant and negative inotropic effects, and small doses have sympathetic stimulation causing increase in heart rate, blood pressure, cardiac output, and oxygen consumption. So overall, there is increase in the blood pressure and heart rate. Coming to clinical uses, it has wide variety of uses as an induction agent in anesthesia and for post-op analgesia, for pain relief in procedures, different procedures, and in chronic cancer pains, non-cancer pains. Ketamine can be given in the form of burst ketamine therapy. Then it has modulation of glutaminergic neurotransmission, AMPA receptor activation, restores neuroplasticity. This modulation of ability of ketamine is used for decreasing the severe depression in psychiatric patients. Coming to actual clinical uses, subanesthetic dose of ketamine is used for management of various chronic pain conditions. So what is subanesthetic dose? Anesthetic dose is 1.5 to 2 mg per kg body weight, but subanesthetic dose is 0.2 to 0.5 mg per kg body weight. So this dose is excellent to give pain relief to the patient. So all pains which are refractory, intractable pains, pains because of complex regional pain syndrome, neuropathic pains, both diabetic neuropathic pain and chemotherapy-induced neuropathic pain, any phantom limb pain, long-standing pains, all pains, the mechanism of pain generation is because of activation of augmentation and activation of NMDA receptor. So ketamine is an excellent drug because of its ability to antagonize NMDA receptors. And for opioid-induced hyperalgesia also, ketamine is drug of choice. Coming to other clinical uses used in children for procedural pain, like changing dressing or cleaning the wound, any small reductions or any reduction of dislocations or fractures. Then for mucositis, severe pain, oral rinse of ketamine is gives very good relief. So just oral rinse of ketamine is very much indicated in case of a severe mucositic patient. Then topical application. Even for non-cancer pains, you can go for topical application. And in psychiatry, it's used for major depression. Nasal route is preferred here. And in bipolar disorder, and also reduces reduction in suicidal ideation patients. Coming to routes of administration, ketamine is used in various routes: oral, sublingual, intravenous, subcutaneous, nasal, rectal, intramuscular, and intrathecal. So for burst ketamine therapy, you go for subcutaneous route. Start with 100 mg for 24 hours. Gradually increase second day to 300 mg and next day to 500 mg for 24 hours, and you can stop the treatment. This is indicated in case of chronic pain not responding to any type of conventional mode of treatment. So this is tried both for cancer patients and non-cancer patients. So burst ketamine therapy is very important. Usage of ketamine in chronic pains. Then coming to side effects. So for central nervous system, it is hallucinations, confusion, sedation, and they have psychomimetic effects like vivid dreams, dysphoria, and drowsiness. These can be taken care of if you co-administer benzodiazepines along with ketamine. Then for cardiovascular system, it is increase in BP and heart rate. Then for ophthalmic, it is increased intracranial pressure, intraocular pressure, visual disturbances, nystagmus, and blurring of vision is noted. So you should be cautious in case of ophthalmic problems, any glaucoma. Then there is a risk of salivation or increase in secretions anywhere, bronchial secretions and salivary secretions. Then tone of the muscles are also increased. So then when administered with opioids, opioid toxicity is one more side effect. So decrease the dose of opioids when given along with ketamine. Coming to long-term effects, when used for long-term for more than 4 to 6 weeks, risk of cystitis and papillary necrosis noted in urinary tract. So the bladder direct effect of ketamine causing mucosal damage causes cystitis and papillary necrosis. Just stop the drug, and you can stopping the drug and just giving a wash of bladder mucosa will heal it. Otherwise, you can go for botulinum wash for the bladder. Then coming to neuropsychiatric complications, mild psychosis, anxiety, and memory impairment are noted. And upper GI tract, there are very mild epigastric pain, GI bleeding, nausea, vomiting. For hepatobiliary system, it is dysfunction of sphincter of body, and stricture of CBD is rare complication. Then important is addiction potential. So this ketamine, when used for long term, you should look for addiction potential, because it's a drug which is notorious for its addiction potential because of its hallucinations. Caution, where we should be very cautious in ketamine usages, wherever there is raised intracranial pressure, seizures, raised intraocular pressure, and glaucoma. Cardiac conditions, again, hypertension, cardiac failure, and arrhythmias, and drugs when patient is on monoamine oxidase inhibitors. These are all absolute contraindications. And pregnancy, breastfeeding, porphyrias are relative contraindications. Avoid in ophthalmic injuries and procedures. And in psychiatric diseases, schizophrenia and post-traumatic stress disorder, these two conditions, don't use ketamine. Compatibility, ketamine is very good drug. It is compatible with almost all the palliative care drugs. Coming to drug interactions, ketamine when used to benzodiazepines prolongs the effect of ketamine and decreases the psychomimetic effects. When used with anticholinergics, decreases the secretions. Small dose of propofol with ketamine and benzodiazepine will be very stable hemodynamically. So this is a good combination. Then propofol with small dose of ketamine is used for sedation along with mild analgesia. So it is called as ketofol infusion. So small dose of ketamine acts as an analgesic, and propofol gives you sedation. Then coming to drug interactions, you should be cautious with any drug which causes potent inducers of CYP3A and potent inhibitors because they decrease plasma levels of ketamine. So wherever we are using these inducers and inhibitors, we should be very careful. These are the list of drugs which cause induction of CYP3A4 and inhibitors of CYP3A4. Coming to recommendations, ketamine and propofol requires expertise for their use and cannot be used easily in our Indian setup. So both are anesthetic drugs. Even phenobarbital is an anesthetic drug, but it is safe in low doses. But ketamine and propofol definitely requires expertise. So they belong to anesthesia drugs. So restricted their use by anesthesia and palliative care specialist only. Then for propofol, the problem is that only IV line is mandatory. Ketamine can be given in any route and it's a drug of choice for refractory pains. So for ketamine, you have wide variety of choices, but propofol IV line. That propofol is mainly preferred in agitated delirium, vomiting, terminal agitation. The latest drug nowadays is dexmedetomidine, which is used for conscious sedation. I did not go into details of dexmedetomidine, but it is the excellent drug used for conscious sedation, where a patient has a sleep mimicking the natural sleep. You can wake the patient up, and it has analgesic potential also, an analgesic property also. Coming to case scenarios, I will give you some 3 or 4 case scenarios. A 65-year-old female patient diagnosed with
Aruna, will be really quick. There are some questions which we need to address.
Yeah, ma'am. Just a case scenarios only. 65-year-old patient diagnosed with carcinoma breast stage 4. She has bilateral lung and liver mets. Presented with severe pain, severe breathlessness. She was on all conventional medications, incremental doses. Then she had almost breathlessness of NRS scale 8/10. She was unable to lie down in the bed flat. So constantly in sitting position both day and night. She was already on all bronchodilator steroids. So family and patient are very much distressed. So we counsel them for palliative sedation. So what is the drug of choice in this scenario? So actually we tried opioid and benzodiazepine continuous infusion. Patient has a very good relief. She was comfortable in her last days of life. Just incremental dose of benzodiazepine along with original dose of her opioid gave her good relief, and she was very comfortable. Then coming to case 2, 28-year-old male patient who was diagnosed with cancer pancreas stage 4, presented with severe pain, abdomen and vomitings. Over a period of time, his abdominal pain was refractory to conventional routine medication. NRS score of pain was 8/10. He was on opioids, adjuvant analgesics, steroids. Even ketamine is also started orally for that patient. Family was unable to see his suffering, so they opted for palliative sedation. So here, what is the drug of choice? So already patient was on some dose of opioids, so we continued that, and we have continued ketamine and started propofol infusion along with the antipsychotics. So patient was comfortable during his last days of life, and he has a good relief, was sedated optimally, and it was a very comfortable end for the patient. Then coming to case 3 scenario, 14-year-old female patient diagnosed with AML and has brain and bone metastasis. Presented with severe back pain, headache and seizures. At one point, the patient is having continuous seizures. They are refractory to all the conventional anti-epileptic medication, even benzodiazepines. So here, what is the drug of choice? So we have added phenobarbital along with the opioids and benzodiazepines, and regular anti-epileptic medications were continued. Child was comfortable with the control of seizures and pain during her last days of life. So the titration of drugs depends upon the clinician judgment. Coming to case 4, this scenario is a 70-year-old male patient with the carcinoma prostate stage 4 with multiple metastasis. He has presented with agitated delirium at his terminal stage of life. Patient was already on antipsychotics, benzodiazepines doses are escalated, but could not control his delirium. Family were opted for palliative sedation. So here drug of choice is propofol infusion we have started. along with his original conventional treatment, along with antipsychotics and benzodiazepines, and doses are adjusted. Patient delirium was controlled, was comfortable during last period of time. He was his delirium was controlled. Then coming to case 5. So this is 30-year-old male patient with stage 4 cancer of ascending colon with liver mets, ascites, and malignant bowel obstruction. He presented with severe vomitings and pain abdomen. Almost NRS scale was 8/10. Unable to sleep for almost few weeks. Since few weeks he was not having any sleep. So his vomitings and pain abdomen are refractory to all the conventional medications. He was on opioids, adjuvants, steroids, antiemetics, and antipsychotics. But here the patient opted for intermittent sedation, wants relief for his symptoms, but wishes to talk to his family for a few minutes in a day. That was his desire. So I will leave this to audience. What is the drug of choice they will choose if this scenario is there? So I will come to this slide again, just one more slide. So coming to take home message, after hearing about all these palliative drugs, which are all depressant drugs on the central nervous system, and which are having so many interactions and so many side effects, so one should be cautious. So the choice of a drug depends upon the clinician preferences and also the refractory symptom for which you want to choose a palliative drug, sedation drug. So it is also important that institute should have a policy and it should abide by the ethical rules and regulations. So all these are very important for going for a palliative sedation. In difficult cases, more than one medication may be needed to sedate a patient. So you should be very cautious, and you should not hesitate to add one more drug when symptoms are not controlled. Initially, you can start with oral medication, then you can go for rectal route also. But to attain a continuous level of desired effect, you have to go for intravenous and subcutaneous. Opioid administration should be continued, never stop opioid, even when you initiate palliative sedation, because never think that unconscious patient doesn't have pain. So opioids are continued. And one important thing is that consent and documentation is very important before going for palliative sedation. Counseling, consent, and documentation. Thank you. And I will come back to the slide which I have put up and asking for what is the drug of choice in this scenario. So audience can answer.
So Gayatri, there are some questions. Please, can you take up quickly all the questions?
Yeah.
Yeah, so I will leave that case 5 as a food for thought. Later on, we'll take it up. But Aruna, if you can just stop sharing the slide, we'll quickly take some questions. Very important. Some comments are given by the audience. Let's take one by one. So I'll go from beginning. Okay. So when to prioritize benzodiazepines over morphine in managing breathlessness? There's one question. Dr. Rajesh Mahajan says.
So benzodiazepines are not first line for breathlessness. Benzodiazepines will be preferred when there is element of anxiety-induced breathlessness to control the panic attacks, and when there is anticipatory breathlessness, you prefer benzodiazepines.
Thank you. Should we really be worried about the adverse effects of palliative sedation in terminal agitation? Please clarify.
No. We have to, that's what I have told you, the ideal medication should have a less adverse effects, and you have to proportionate your medication. The amount of medication is just proportionately given so that patient have sedation effect and control of his suffering, and not that you have to monitor with sedation scales like RAS scales. So you should not leave the patient, you have to assess it, and don't go for deep sedation. So palliative sedation, as by definition, it's a proportionate amount of drug chosen to sedate the patient for relieving his symptom or suffering, and not that you are sedating it to grade 4 or deep coma level. So that is not the intention. So it's just relieving the suffering.
Thank you, Aruna. It's important that we should not at the cost of side adverse effects. So we have to balance and use some scales to assess the symptoms, assess the distress, and assess the level of sedation. It's very important. Thank you. Is change in urine color on propofol infusion a harbinger of propofol infusion syndrome?
it's not. It's only a change in color because of presence of phenols or uric acid, but it doesn't stop. We need not stop the infusion. It doesn't cause any renal change in renal parameters. So we can continue, but we should be cautious in case of hepatic.
Thank you. Can ketamine be used in absence of anesthetist?
So since I already told it requires a little bit of expertise, you can use other routes. You can use if you are thorough with the drug, pharmacokinetics and dynamics and its hallucinations and abuse potential. If you are aware of it, you can start with slowly with the nasal route or with low doses. But for subcutaneous infusion and intravenous infusion, definitely anesthetist should be there.
Maybe there's an anesthetist speaking, but I'm aware that many palliative care centers, in the absence of anesthetist, they use as a burst ketamine. So it's a matter of experience and again getting familiarizing with drug. That's what my thought would be. Yeah, but we should be cautious and how you use it. Infusion propofol in agitated delirium versus haloperidol infusion.
Yeah. When antipsychotic haloperidol is not giving relief, that is called as a refractory agitated delirium. So there propofol is an excellent drug because we have seen patients even on haloperidol, they have delirium symptoms not controlled. So propofol definitely is a good drug of choice when there is refractory delirium.
So first choice is antipsychotic, then propofol. It's not a versus propofol. Ketamine in severe oral mucositis is healing or just to relieve pain? Also, how is the mode of use?
So ketamine for oral mucositis, it gives relief almost for, I have used in one patient at our setup. So it gave almost 4 hours of relief, and he has holded that ketamine drug for almost 1 minute. So I asked him to keep it in the mouth for 1 minute.
Relief of pain.
Yes.
Yeah. Okay. Next question: dexmedetomidine and phenargin for sedation. Any experience you have dexmedetomidine or phenargin?
Dexmedetomidine, I have a good experience. I used for ventilator patients for conscious sedation. In palliative care, I never tried because of its cost effectiveness. It's very costly. For patients on ventilator, actually it's just mimics like a natural sleep. Infusion of almost 0.2 to 0.8 micrograms. You can wake up the patient like you are waking up from sleep. They will respond to you and again they will go back to sleep. And excellent thing is that with dexmedetomidine, both sedation is there and analgesic property is also there. So that gives you relief for both the pain and also if patient wants sedation and want to talk to the patient, to their family or to the clinician, I think I'm favorite of this dexmedetomidine.
Yeah, it's expensive, but slowly for me it's emerging as one of the favorite drug for my clinic. I would prefer many contexts, especially neuroirritable conditions in children, and it can be given subcutaneously. It's much more yes, we have to be worried about hemodynamic conditions. Dr. Shobha has shared very nice reference article for us to read and understand a little more about dexmedetomidine. Dr. Rajesh Mahajan asked something about propofol ketamine combination, I think.
And one more thing is dexmed is limiting factor is one is cost and another is cardiac effects. It causes severe brady and hypotension. So one should be cautious regarding these cardiovascular effects. Then coming to next.
Propofol ketamine.
Propofol ketamine, I tell you that you are choosing more of propofol, less of ketamine. That is good combination. You will have good sedation and little bit of analgesia. If ketamine is more than propofol, then again when there is pain more, then you go for a more amount of ketamine, dosage of ketamine than propofol. So these two combinations are clinician decision depending upon the patient's condition. So more of propofol is for sedation, more of ketamine is for pain relief.
Thank you, Aruna. That's wonderful. I thought we learned a lot today. We will have this, hopefully this presentation is a reference for all of us to go back to, suppose we want to just quickly refer to these medications. And also we have to understand what is palliative sedation? Definition, let's refer to always that. And second thing is that it's not a standard formula for all patients, fixed dose of morphine, midazolam, haloperidol. It's not like that. It has individually, we have to titrate depending upon the indication, the need, and the circumstances. And finally, documentation and consent, and the documentation is very important. Thank you, Aruna. That was very useful. Over to you, Dr. Sushma.
Thank you, Gayatri and Aruna. Thank you everyone for joining, and thank you asking for a lot of questions. And this shows that you are very you were listening this lecture carefully. And learning medication is very important, and we have to learn all the medications. But every patient is going to be different. But your knowledge will govern how to use these medication on different patients. Thank you very much.
Thank
We
you,
will
madam.
see you next week, Monday before 6:30.